Thank you very much. It's a pleasure to be here. I'm going to talk about some new insights into the treatment of relapsed and refractory myeloma. You've already heard in other talks that we have a panoply of choices. Here's the updated NCCN guidelines. And I just put it's sort of my menu of the way I think about things for relapsed disease in the sense that if you ask, what do we really know in patients whose myeloma is resistant to both lenalidomide and bortezomib from randomized trials, we have Kyprolis, pomalidomide, dex, and Daratumumab, pomalidomide, dex. Some of the other regimens that you know that have been combined with lenalidomide, dex, such as Elo and Kyprolis and even Daratumumab, were always done with lenalidomide, dex in the control group, so the myeloma was sensitive. If you look in terms of multiply relapsed therapies, we really do go primarily to Daratumumab-based regimens. Panobinostat as an HDAC inhibitor is not used very often. Now, I wanted to just mention a couple of quick updates. You've heard these, I think, in other talks, but recently, carfilzomib Endeavor trial was updated, carfilzomib dex versus Velcade dex, and showed a survival advantage, which I think is really important in relapsed myeloma. And similarly, the trial of Elotuzumab lendex versus lendex, the so-called Eloquent trial, was updated, and at 4 years, the triplet had a survival advantage. So, what else can we say about what the regimens are that already exist? Well, in the Daratumumab regimens, you can get minimal residual disease. On the left is Daratumumab with lenalidomide dex, and on the right is Daratumumab with bortezomib. But if you get minimal residual disease, you can have a superior outcome. Now, what's one of the ways that we might go forward with these antibody-based regimens? And I just put in one slide. It turns out that some drugs, and in this case I used HDAC inhibitors as an example, can change things for the better. They augment the antigen expression, CD38 and HLA, and they can upregulate the effector cells. So it may be that although we have antibodies and triplets now as a baseline, that we can do better by both modifying antigen expression and also effector cells. What I really want to talk about is 3 areas that I think are very exciting. How can we further exploit targeting protein degradation? How can we do better in terms of immune studies and therapies? And what are we going to do about the genomic chaos that we have in myeloma? So firstly, we all together have targeted the proteasome repeatedly, and in fact, you can target upstream of the proteasome the same pathway, and this is one example of targeting the ubiquitin proteasome receptor, which honestly brings the ubiquitin protein to the proteasome for its degradation. And in fact, we've actually studied this in some detail. We have a drug now, or we think it's worth studying. RPN13 is the ubiquitin proteasome receptor, which is upregulated in myeloma, but not normal plasma cells. It's present in patient cells on an immunoperoxidase and on a protein level. And if you have a high level of this ubiquitin proteasome receptor, you don't do as well. Now, we've made a drug against this ubiquitin proteasome receptor, at least a prototype, and in fact, it's called RA190 right here. If you take out RPN13, you knock out the receptor, the drug doesn't work anymore. It causes the accumulation of protein by blocking upstream of the proteasome, but it doesn't. Here's Velcade blocking the proteasome. It doesn't block the proteasome. It still causes accumulation by going upstream of the proteasome. And the reason we're excited about it is this. These are 5 of my patients with myeloma. Their myeloma is resistant to proteasome inhibitors, and in a dose-dependent way, it's sensitive to this ubiquitin proteasome receptor by causing this massive accumulation of protein. So maybe we can overcome proteasome inhibitor resistance. You all know that we've done a lot, and you've heard at this meeting, with proteasome inhibitors. More work is happening with inhibiting the other pathway, the agrosome. Panobinostat can do this, so can another selective inhibitor. And I'll just mention to you that this selective inhibitor is well tolerated, and it is going forward now in combination with proteasome inhibitors. The idea here is not going upstream in the same ubiquitin proteasome pathway, but it's blocking the ubiquitin proteasome pathway with the proteasome inhibitor and blocking the agrisome pathway, which is the only other pathway with the HDAC inhibitor. Now, one thing that I think is really exciting, and in future meetings here, we're going to be talking about a whole new class of medicines. Because in contrast to blocking protein degradation, which is what proteasome inhibitors do, and the ubiquitin proteasome receptor, you all know that the IMiDs bind to cereblon and they trigger the degradation of proteins. That's really special, but we and others are exploiting this characteristic with a whole new class of drugs that are called Degronimids. These are drugs that bind to cereblon, sure enough, and they turn on the degradation system, but they link to a substrate protein that you might want to degrade. So think of it, you can degrade a protein substrate selectively. And so, for example, you can get rid of a hormone receptor on breast or prostate cancer. We have one now to BTK and CLL. And it may be you can degrade proteins that are obligate for viral replication. But a whole new class of drugs coming out of the IMiD observation. Very quickly, you know that the checkpoint inhibitors have been an interest in cancer in general, also in myeloma, because PD-L1 is expressed on myeloma cells. It's also expressed on other accessory cells like myeloid-derived suppressor cells and plasmacytoid dendritic cells, which actually promote myeloma cell growth and suppress the PD-1-bearing immune effector T, NK, and NKT cells. So in myeloma, if you block a checkpoint, you relieve the immune suppression here, but you also abrogate the effect of these accessory cells. And so here's one slide I love to show. It's a single patient with myeloma. It's autologous myeloma cells with the patient's own T cells. And this is killing on the y-axis with the checkpoint inhibitor PD-1 and PD-L1, with the IMiD lenalidomide, and then with the two together, you can really augment killing. So the preclinical data is very exciting. As you all know, this has really translated to the clinic, and we have trials for here, PD-1 pembrolizumab with lenalidomide dex, and the same with pomalidomide dex. And you know that even though they had response rates of 50% in both cases, even in patients whose myeloma was resistant to lenalidomide or pomalidomide, these trials have been stopped because of excessive toxicity in the checkpoint-bearing cohorts. Time will tell, but I most sincerely hope that we can exploit checkpoint inhibitors and combination immune approaches in myeloma because they have great promise. Now, I think that the best target in myeloma is going to be BCMA, with all due respect to CD38 and SLAMF7, because it's more selective on myeloma cells. It causes long-lived plasma cell growth by NF-kappa B signaling, but it also causes growth, survival, and drug resistance of myeloma cells. And the most important ligand in the bone marrow plasma of your patients is APRIL. So we are already testing together with our clinical team and Paul Richardson immunotoxins that are linked to BCMA. They deliver an auristatin toxin to the tumor cell, and they also maintain their antibody-dependent cellular cytotoxicity. There's some early promising data. Another way of targeting BCMA is actually using BCMA to deliver T cells locally, and hopefully in so doing to generate a localized immune response, as has been done in ALL and other tumors. I think, and I think you mostly would agree, that the CAR T cell concept is probably the most exciting that we nowadays have. This is one example of a vector with BCMA. The co-stimulatory molecule is 4-1BB. In animal models and in vitro, in fact, the CAR T cells are very effective. But what I've done on the next slide is to summarize all of the CAR T-cell studies with BCMA and multiple myeloma to date. There are several studies from the NIH, from Novartis, Bluebird, and from China, but we see very high response rates, 19 of 19 patients here in the Chinese study. Very exciting, but I would hasten to add that cytokine release syndrome, in particular central nervous system edema, still makes these quite risky, if you will. There's a lot of work that can be done and is being done to make them more potent and selective and active on the one hand, and to reduce the cytotoxicity on the other. And I just want to finish with the BCMA by saying there's another way you can exploit BCMA. The natural ligand is APRIL. It's made by osteoclasts and macrophages in patients' bone marrow. It binds to the BCMA on the evil myeloma cell, and it promotes growth, survival, and drug resistance. Even worse, it upregulates checkpoint inhibitors, so it confers immune resistance. So we have now 2 humanized antibodies to APRIL we're studying in the laboratory to go to the clinic to abrogate this effect of growth, survival, and drug resistance of the tumor cell, but also hopefully to restore immune sensitivity. And finally, just a couple of comments about the genomics, having talked about protein homeostasis and a little bit about immune approaches. Here is a circus plot of one of our patients. Very complicated when you sit down and see a new patient with myeloma, many substitutions, deletions, insertions, and rearrangements. And as the disease progresses, this picture becomes even more complicated. And as you all know from many folks' work, including Nikhil Munshi in our center, this is clonal or subclonal. Patients can present with 3 to 5 clones at the time of diagnosis and can relapse with a new subclone, can relapse with a more predominant subclone, or they can have a subclone to start with which goes away. So what are we going to do about such a complicated genomic picture? Well, one thing we can do, and this is from Faith Davies' work, is look at the frequency with which mutations are present. The RAS-RAF-MAP kinase pathway is the most commonly mutated, and so especially NRAS and KRAS, and there have been trials of single agents and combinations, but they've so far only resulted in transient benefit. I think the first example of personalized medicine in myeloma is this one. It's venetoclax, of which you've heard undoubtedly from Shaji Kumar and Larry Boyce and other workers. But in the patients who have 11-14 translocation and who have overexpression of BCL2, venetoclax, that you know so well from lymphoma and CLL, can have response rates as high as almost 90%. And it's going forward for registration now, venetoclax to block BCL2 together with bortezomib to block BCL1, or MCL1 in multiple myeloma. I think the new things I want to leave you with is that in our center we're studying again with Dr. Shamas and Dr. Munshi, what are the problems underlying all this genetic complexity at diagnosis and at relapse? 4 processes: homologous recombination, apex nucleus activity, pan-nuclease activity, and apobec activity are all elevated in myeloma, and we are making now, with high throughput screens, inhibitors of these processes, hopefully in so doing to get to the underlying hallmark causes of this chaos. In the meantime, what we're also trying to do is target the consequences of the genomic chaos. So turn the myeloma cell against itself. And in particular, here's one example in patients who have MYC amplification in myeloma. They actually have a particularly bad prognosis here. And so what we've done is, in the patients who have high MYC levels, it turns out by virtue of that, they have high levels of replicative stress, which can be blocked by ATR oral inhibitors. Oxidative stress is already high. You can increase this with proteasome inhibitors such as Velcade. So combining these two can actually put the myeloma cell over the edge with stress and induce apoptosis. And the final concept I want to leave you with is of epigenetics, because as you've heard in other cancers, it's happening in myeloma too. There's a demethylase KDM3 that is active in myeloma. It's important Because it's active, methylation at promoters of genes like IRF4 is allowed to occur, and if you block KDM3 and you restore methylation, you can block the transcription. And this has effects not only on myeloma cells, but in the microenvironment. And the final epigenetic example I want to mention to you is brand new. KDM6 is also upregulated in myeloma. It turns out KDM6 in myeloma is controlled by NF-kappa B, but look down here. It in turn regulates the most important growth pathway. So we're trying to make prototype inhibitors to this demethylase. So what I've tried to tell you in the review was that we use triplets, but I at least think in the North America, where we commonly use lenalidomide, bortezomib, dex, the triplets that I think should be used are carfilzomib, pom-dex, and daratumumab, pom-dex. I tried to tell you about promising immune therapies, CAR T-cells, BITE, checkpoint inhibitors, and combinations. The idea that we can target ongoing DNA damage and someday limit it, and I hope venetoclax being the first example of personalized medicine in myeloma. Thanks very, very much.